symptom that is persisting all over the world. So they are in the Montreal Declaration by the International Pain Summit of the International Association for Study of Pain in 2010. They declared that the access to pain management is a fundamental human right. That it's right of all people, despite caste, color, creed, or anything, to have access to adequate assessment and treatment of pain by a trained healthcare professional. Pain is, of course, a very difficult thing. It's not easily manageable unless you are trained in that. So, basic principles of analgesic use. So, whenever we want to provide a medication, we have to go for certain principles, like by the mouth. That's preferably the analgesic should be administered through oral route. Um, and by the clock. This is very important because by the clock means we want to assure pain relief throughout the day. That is 24 hours, the patient should get pain relief. So why it is important that pain may be present throughout the day. So we doesn't want the patient to suffer due to the pain. So like paracetamol, if the duration of action is 6 hours, it should be prescribed 6 hourly so that the patient are pain free for the next 24 hours. And by the ladder, that means the pain medication should be by the ladder. That means the pain medication should be ladder. So adequate pain, so adequate analgesic, which is needed for the pain of the patient should be prescribed for the patient. And the dose should be always individually titrated. Pain is a subjective thing. It's one pain for one person may not be the same for another. So each person, the pain will be different. So the medication also need to be chosen accordingly, and the dose should be titrated accordingly. So what dose the patient get relief would be the adequate dose. And keep attention to the detail. Each and every detail should be looked for. So whatever we can do to relieve the pain, we have to look for. So these are the principles, basic principles of usage of pain medication. See, the WHO Analgesic Ladder, it's based on recommendations of a group of international experts. WHO, the World Health Organization, came with a step ladder approach to manage cancer pain in 1986. So translated into 22 languages and served as helping us treat pain worldwide. So this is a stepwise approach to treat pain cancer, depending on the severity of the pain. Hope you have learned about the pain assessment, where one of the important points that you assess is severity of the pain. You assess the pain, yes, how severe the patient's pain is, and the patient answers you mild, moderate, or severe based on the scale that you use. And depending on the severity, we have to choose pain medication. That is what WHO Analgesic Ladder is. So this legitimate the use of opioids and easy selection of pain medication. So this is a WHO Analgesic Ladder. So if you see, there are 3 steps. The first step is for mild pain, where we give for when a patient complains of mild pain, we give non-opioids and adjuvants. Non-opioids are paracetamol or NSAIDs, which are used along with or without adjunct group of medications called adjuncts, which we'll discuss later. So that's the step 1. So mild pain, we give non-opioids and adjuvants. If the pain is moderate, we go for opioids for mild to moderate pain. That is tramadol or codeine. Those are called as weak opioids or opioids for mild to moderate pain. Those are used along with the step 1 medication. Next, if the patient is complaining of severe pain, we go for the third step, where opioid for moderate to severe pain are used along with step 1 medication. If this step 1 medication is common for all steps, so any patient who's complaining of pain, we have to start step 1 medication. If severity is moderate, we also add opioids for moderate pain, or if severe, we choose opioids for severe pain. So based on the increasing or the persisting type of pain, severity of the pain, we choose which medication. So this is what basically WHO Analgesic Ladder says. Simple, easily understandable, it's internationally validated tool. Effective and cost effective also. It's very much effective mainly, and uh, it helps us reduce unwanted resource wastage. Can be implemented across the world, even in underdeveloped countries. It's well suited for home care also, and also applicable for non-cancer and acute and chronic pain also. So hope WHO Analgesic Ladder is very it's clear for everyone. So based on severity, we choose which medication to use. So WHO Analgesic Ladder helps in selecting that. So discussing more about each step. First step would be non-opioids. Here for mild to moderate pain, as it usually associated with inflammation, or which we call as which are nociceptive due to passive sensation through the nociceptors. Most common medication we might all have in use would be paracetamol, also known as acetaminophen. So it has both antipyretic, it reduces temperature, and also analgesic action. Normal dose that we would be 500 to 1 gram in 4 to 6 hourly. Maximum dose advised would be 6 gram in 4 to 6 gram in 24 hours. Dose reduction is indicated if weight is less than 50 kg. One of the advantages of the paracetamol is it can be applied through rectal route also, so that when oral route is compromised, rectal route can be taken. Overdose of paracetamol can cause severe hepatotoxicity. So this is the question: is it safe in liver disease? So if a patient comes in a severe pain, but has liver disease, can we use paracetamol? Can I expect answers from you? Is it safe in liver diseases? Anyone know? Anyone? Anyone thinks it's safer? Yes, with dose titration. Good. So moving forward, it is safer to use even in situations with alcoholic liver disease or cirrhosis or hepatocellular carcinoma, cholangiocarcinoma, any conditions where a short-term use less than 2 weeks, we can use up to 4 gram. But in long-term use, it's also safer, but you have to reduce the dose. Dose would be ideally it should be less than 3 gram per day. So ideally we can give 500 milligrams 6 hourly. So even in chronic liver diseases or severe liver disease, we can use uh, paracetamol in a titrated dose. It's not a contraindicator. Because even in chronic pain, paracetamol can be acted as an NSAID sparer, where beneficial will be in terms of reduced adverse effects. See, paracetamol is one of the comparatively safer drug and cost effective and easily available, so it can be widely used. But even though it has lesser side effect profile, so if it's compared to NSAIDs, it has lesser side effects, so it can be used as an NSAID sparer. So think of someone who is suffering from a osteoarthritis, very elderly person who might need long-term pain medication. NSAID may not be a good option here because of the adverse profile, where paracetamol can be substituted. Hope I'm clear. So it has a good safety profile, no adverse effects on gastric mucosa, well tolerated even in patients with peptic ulcer, no adverse renal effects, no effect on platelet function, and is tolerated by 2 by 3 of patients who are sensitive even to aspirin. So this is why paracetamol is most preferred. So negative sides, it has needs significance of administration. You need to take at least 6 hourly. And there is a potential for hepatotoxicity. So there are 10 points where that should be considered in patient taking higher doses, more than 4 gram per day, or impaired liver function. A patient has history of alcohol consumption, or body weight is less than 50 kg. In such situations, there's a potential for hepatotoxicity, so keep an eye for that. Moving forward, next group of non-step 1 medication are NSAIDs. So how do NSAIDs work? See, when a stimulus comes, what happens is the arachidonic acid comes through the in our body get converted into inflammatory. Sorry, the inflammatory mechanism happens, so the prostaglandins get released. The arachidonic acid get converted to prostaglandins and other inflammatory reactors by the help of COX enzyme, the COX, cyclooxygenase enzyme. So these prostaglandins and other inflammatory reactors, they cause the pain and inflammation. So what NSAIDs help is NSAIDs act on the COX and prevent its action. So this conversion doesn't work. So there is no pain or inflammation. So that is how NSAIDs work. So based on this action, the cyclooxygenase enzyme, it is of two types, COX-1 and COX-2. COX-1 increases inflammation around of folds. It mediates thromboxanes. And one additional thing is it helps the gastric mucosal protection from the acidic gas. The acidic pH, this COX-1 protects the gastric mucosa. So what happens is when COX-1 is stopped by the NSAID, the gastric mucosal protection is tampered, so the patient gets acidity or the gastritis. That is why NSAIDs always cause gastritis, because the COX-1 is inhibited. Okay, COX-2 enzyme is inflammatory in 20 folds, but also cause vasodilatation and inhibits platelet aggregation. So these are two types of the enzymes that act. So this is important because we know there are a large number of NSAIDs, the non-steroidal anti-inflammatory drugs. Based on their action, they are divided, and we need to choose the NSAID. There are non-selective COX inhibitors. They block both COX-1 and COX-2 enzyme, like mefenamic acid, mephthal. There are preferential COX-1 inhibitors. They preferentially inhibit COX-1 as an aspirin. So preferentially they are inhibiting COX-1 because and causes, hence they are more not tendency to cause gastritis. Preferential COX-2 inhibitors blocks COX-2 preferentially more than COX-1. Diclofenac or nimesulide and selective COX-2. These are celecoxib and heterocoxib are the only two available now country. And they selectively inhibit COX-2 inhibitors. And they doesn't involve COX-1. So the gastric mucosa is not tampered because of COX-2 inhibitors. So they will be safe in patients with history of gastritis. So whenever we are choosing medication, the least risky medication should be tried first, with escalation if first medication is ineffective. So especially starting with paracetamol at lowest doses in short-term needs. And just keep in mind, despite potential for abuse, narcotic medications for short-term pain relief can be. So what are the short-term adverse effects of NSAIDs? potential nephrotoxicity. So it will tamper with the blood supply of kidney and cause nephrotoxicity. So hence it can precipitate renal failure, acute renal failure, and alter with the bleeding parameters. So the risk factors for these are dehydrated or hypovolemic. So whenever a patient is on NSAIDs, advise them adequate oral fluids and prevent dehydration. Make it a habit of advising them to take enough water when they are taking NSAIDs. Also, concomitant use of diuretics or antihypertensive medications like ACE, other antihypertensives. Pre-existing renal or heart diseases, poorly controlled diabetes, and recent contrast for imaging. So these can be considered as risk factor for nephrotoxicity. Long term, it is more of a gastric ulcer or hemorrhage or perforation, which is very common in previous years. Now, lesser because of the PPIs has been introduced. Ibuprofen is considered as one with the lowest risk. Naproxen with intermediate and paroxysm has higher risk of gastric ulceration. The risk factors of gastric ulceration is age more than 65, concomitant steroid use, aspirin or anticoagulants, previous history of ulcer or GERD, thrombocytopenia, and long-term uses. COX-2 inhibitors, they are safe in renal, gastric issues. Does not COX, affect on COX-1, so safer for the gastric mucosa, but they doesn't come without a cost. They have a high risk for clot formation, so they are high. They are contraindicated in heart failure, stroke, ischemic heart disease, and peripheral vascular diseases. So the vascular issue is there, so they should be prevented. They should not contraindicated in such situations. So always screen for hypertension, diabetes, or dyslipidemia, or smoking in the patients. And diclofenac as a comparable cardiovascular risk to the COX or the COX-2 inhibitors. Uh, so lower doses of ibuprofen is one of the comparatively safer one medications, like 400 milligrams twice a day doesn't show much increased risk. Usually seen as a safer dosage. So now you know, based on the COX, the action on the COX enzyme, you have differentiated medications to different types. You know the contraindications, adverse effect. Now the idea is that you select the medication according to the patient. So very young patient who comes with a mild pain, with a history of gastritis or GRD, the safer NSAID for him would be a COX-2 inhibitor, etocoxib or celecoxib. But it is the same person. If the person is above 50 years with the risk of hypertension, diabetes, or hypertension, dyslipidemia, for them, COX-2 should not be given and can give maybe a low dose of ibuprofen. So, looking into the patient parameters, we need to select which NSAID we can use for them. So, whenever you are giving NSAIDs, administer with gastroprotective drugs. Make sure the patient is on proton pump inhibitors or Ranitidine. Look for history of acid peptic disease or advanced age, smokers, alcoholics, steroid users, cardiac issues, hypertension, asthma, renal function. Ensure adequate water intake. Avoid hydration. And avoid if there is a bleeding tendency. And COX inhibitors are contraindicated in either sclerotic disease or cardiac disease or cerebrovascular diseases. Step 2 medications, where the medications we use are for moderate pain. They are used with or without non-opioids or adjunct drugs, depending on the patient. Step 2 medications are not controlled drugs, more easily available and widely used. It is given for pain of moderate intensity, not controlled with step 1 medication. One thing is there is no pharmacological need of step 2 medication, especially in children. There is no step 2. For children, because of the side effects of step 2, uh, step 2 medications in children. After step 1, we start with step 3 medications. So tramadol is not new advised for children. Tramadol is a centrally acting drug. It has two modes of action. It's a mu-opioid receptor agonist, so it's a weak opioid, and it's also has a SNRI action. The synaptic reuptake of serotonin and norepinephrine is blocked. So, because of this action, it has a better result in neuropathic pain and it's a less tendency for respiratory depression or addiction. So, tramadol is much better than morphine in neuropathic pain. One thing is, it is more high bioavailability, oral bioavailability. Like oral dose is more potent. That's a 1/5 of morphine, but IV morphine is only IV tramadol is only 1/10 as potent as morphine. So when a patient on IV morphine complains of inadequate relief, he might benefit more from oral route. The patient might ask for injection, but tell them a tablet has more oral bioavailability. It is more potent compared to the IV route. So tablet would be better for tramadol in such patients. Side effects: nausea, vomiting. One of the most like dose limiting adverse effect of tramadol. Very common. We might see most patients returning to us with complaining of nausea, vomiting. They will stop taking the medication. Then the dry mouth, constipation, dizziness, sedation. So like nausea and vomiting, you might have all seen. So which medication will you give along with the tramadol to prevent nausea and vomiting? Which medication has you seen in your center? Emised. So Emised or ondansetron. Any other medications that you use? Any of the centers? So everyone might be using ondansetron. See, you will learn more detail in the coming sessions in GI symptoms. But vomiting or the nausea, both are initiated by certain centers in the brain. We call them the vomiting centers. One of them is like you might all be common with that motion sickness. So the center associated with that is a vestibular in the vestibular region. So when a patient travels or the motion sickness happen, the vestibular center activates and give instruction to have the instructions so that the body start experiencing nausea and vomiting when the due to motion. So we need an antiemetic which will act on motion sensor, this part of the brain. So that is why cyclizine or certain antihistamines are the drugs used for motion this. Likewise, for chemotherapy drugs, it is due to action on another center. So we use ondansetron for chemotherapy-induced vomiting. But in case of opioids, the center in the part of the brain which get activated is called CTZ. That is the chemoreceptor trigger zone. So The patient starts vomiting when put on opioids like tramadol. It is because of action on CTC. So we need medication which acts on CTC. Unfortunately, ondansetron is a wrong process because ondansetron doesn't have action on CTC. The drug of choice which has action on CTC is haloperidol, uh, domperidone, and metoclopramide. So comparing uh, the adverse effect profile, metoclopramide and domperidone are commonly used, and haloperidol is the even though it's a drug of choice for an opioid-induced nausea and vomiting, we use metoclopramide because of the adverse effect profile. So metoclopramide should be given along with tramadol rather than ondansetron. We will learn more in the coming sessions. Okay. So next drug is codeine. It's 1 by 10 more potent than morphine. Duration of action is 4 to 6 hours. Thing is, it needs CYP2D6 enzyme. Helps in getting in the enzyme to work. The conversion into the its byproducts and cause pain relief. In certain good number of people, this enzyme would be absent. So for them, this medication may not work. Another drug is tapentadol, very common, newer drug. It has similar, everything is similar to that of tramadol. A mu receptor agonist and SNRI action. But compared to tramadol, this has a better side effect profile. Side effects are much lesser for tramadol compared to tramadol. So tapentadol is commonly used, increased being be used now, but being a newer drug, the cost is on the higher side. It is even available as nasal sprays. Another issue with tramadol is it will lower the seizure potential. So anyone with a history of seizures, tramadol can induce seizures by lowering the seizure threshold. So it is better avoided in patients with seizure history or metastasis to brain over at threat of seizures. I'll firstly go through this class of drugs called adjuvant drugs. So these are pain drugs have pain analgesic property that they will help with pain relief, but primary indication is not for pain. And they are also called co-analgesic because they are used along with the analgesics of WHO analgesics. So these medications are not primarily painkillers, but has used because of their properties which help with pain. See, like I mean, antidepressants. There are certain antidepressant medications which use. You might all be have seen be prescribed with pregabalin. Pregabalin is very commonly used for neuropathic pain, but pregabalin is not a pain medication. It is an anti-epileptic or an anticonvulsant, but we are using it because of its property which help with pain relief. So these medications are called as adjuvant medications. So, going through the neuropathic pain, adjuvant drugs for neuropathic pain. So, neuropathic pain is seen in around 40% of patients with cancer. It could be due to direct invasion or compression of the nerve or treatment itself, like chemotherapy. Certain chemotherapeutic medications can cause neuropathy, or radiation can cause the surgery. So, the common medications for use are anticonvulsants and tricyclic antidepressants. So, this is the neuropathic pain ladder. So, when a patient comes with neuropathic pain, along with the step 1 medications, we step 1 or step 2 or step 3, according to the severity of the pain, we use an adjunct. We either start with a tricyclic antidepressant or anti-epileptic. If the pain doesn't leave with that, we add both. If the patient was started on tricyclic antidepressant like amitriptyline, we will add a anticonvulsant like pregabalin. Still not relief, we will switch to NMDA blockers like antagonists like methadone or ketamine. And if not relief, we have to go for interventional pain or IV lignocane medication. So this is how it treats the neuropathic pain. Antidepressants are the first line treatment for neuropathic pain. So many often people will think like why the doctor give me uh, antidepressant, a psychiatric medication for my pain. So we have to tell them that they are used as adjuvant analgesic to reduce the pain. And see, antidepressant action acts at a very higher doses. Think of amitriptyline. The antidepressant action starts at 150 to 100 milligram, but those we are using for pain would be 10 to 25 or 50 milligram. And it has an added action. It is more beneficial, would beneficial in patients with depression, anxiety, or insomnia. Amitriptyline is very commonly used. It's a tricyclic antidepressant. Or SSRI, SNRI, like duloxetine is also used. Duloxetine is the drug of choice in diabetic neuropathy. See, being antidepressants, they have a good number of side effects, especially tiredness, drowsiness, mental clouding, increasing suicidal tendency, and the commonly seen anticholinergic or the antimuscarinic effects like dry mouth. Patient will complain of severe dryness in mouth, acute angular glaucoma, worsening blurred vision, tachycardia. It can affect the increase the QTC, acuity, prolongation. So cardiac toxicity is there, urinary retention. So prescription in people above many male above 50 years should be a concern because of the risk of urinary retention and can add on to the constipation. See, we usually advise the patient to take this tricyclic antidepressants usually at around 6 or 7 o'clock, so that because of the drowsiness, when they wake up, the early morning tiredness or sedation can be avoided. So once they take around 6 o'clock or 7 o'clock in the evening, they will be sleeping throughout the night. So early morning sedation will be avoided. Contraindications are severe cardiac issues, arrhythmia, heart failure, prostatic hypertrophy, glaucoma. Anticonvulsants or anti-epileptics, they were used as first-line neuropathic pain, gabapentin and pregabalin, but currently the studies say antidepressants are the first line, should be used as a first line. So the advantage is they have proven in neuropathic pain, good tolerability compared to the side effects of antidepressants. These are lesser and less drug-to-drug interactions compared to them. Here also the adverse effects are same, some are similar, somnolence, tiredness, dizziness, fatigue. So gabapentin and pregabalin are commonly used. Also, sodium valproate can be used for neuropathic pain. Other drugs we use are NMDA blockers, methadone or ketamine. When first line medication or second line medications doesn't work, ketamine is given as oral medication or subcutaneous or IV ketamine. Certain times, in severe situations, burst ketamine therapy, where a large pulse of ketamine is given over a period of 3 to 4 days. So ketamine has a severe threat of psychomimetic effect. So haloperidol or benzodiazepine should be given before starting ketamine. Then comes the local anesthetics, lignocaine or lidocaine, which are also useful for neuropathic pain, where they are given as infusions. The corticosteroids, another group of adjuvant medications that we very commonly use. See, when a tumor is there will be always a local edema surrounding the tumor. We call that a peri-tumor edema. So steroids are really useful here. Suppose this tumor is compressing a nerve and causing pain. So if nothing can be done for the tumor, if we start steroids to the patients, Then steroids will reduce not the size of the tumor, but the peri-tumor edema will reduce, so that some relief will be given to the compression. Hence, steroids may be helpful in such situations. And steroid has a wide multi-purpose role. Helps with neuropathic pain, helps bone pain. See, it's one of the only drugs that crosses the blood-brain barrier and reduces the intracranial pressure. So that headache due to the increased intracranial pressure can be reduced steroids. Arthralgia, obstruction of hollow viscous or organ caspal dysfunction, uh, pain from spinal metastasis, all those were steroids help. Also, steroid is only a drug which has proven to show improvement in loss of appetite. It can improve the appetite for a period of 2 weeks when dexamethasone is given as 2 milligram, but not beyond a period of 2 weeks. It doesn't work. So steroids mainly work as reducing the edema and anti-inflammatory effect and as a mood elevator. And long-term use of steroids can cause myopathy, adrenal insufficiency, and immunocompromised state. Dexamethasone is a steroid that we commonly use in a palliative setting because of the long duration of action. Half-life is 36 to 54 hours. One of the thing is it can be given as a single dose. We need not divide the dose and give. It can be given as a single dose. And it has a less mellocorticoid effect. So edema and all are much lesser in dexamethasone. Steroids can cause sleep disturbances. So better give in the morning. So we have a practice that we don't give steroids after 4 o'clock in the evening unless it is an emergency or need. Always make sure a gastroprotective agent is given along with steroids because it can cause gastritis. And in long-term therapy, even patients who require long-term, we have to give the lowest effective dose. That is, if we start a patient on 8 milligram or 16 for a few days, we have to taper it down to 8 because of the side effects. So, to risk of that, we try to give the lowest effective dose. From 16, we try to reduce to 12. If patient is comfortable, we reduce it to 8, then to 4. If no issues, we try to maintain it at a 2 milligram at least, the lowest dose. Or if the patient, when reducing from 8 to 4, the patient symptom came back, we will have to raise back to 8. So 8 would be the lowest effective dose for that patient. Other analgesics are GABA agonists like baclofen. When there is spasm, muscle spasm, the pain associated with that, GABA agonists or baclofen would be commonly used. Bone pain, uh, usually seen skeletal metastasis from breast, lung, or prostate, multiple myeloma, etc. So what happens is this disease spreads the bone and causes severe pain, and also causes skeletal muscle related, skeletal related events like fractures or severe pain. So drugs we can use are corticosteroids and NSAIDs. Bisphosphonates are another group of drugs very commonly used as zoledronic acid. Once a month injection is given. Denosumab is newer drug. It's a monoclonal antibody, but it is very expensive. Palliative radiation is one treatment option there. So bisphosphonates like zoledronic can be used. Radiation usually advise a single fraction radiation, but there is chance of recurrence, so it is divided into 10 fractions as given. That's the most common palliative RT for radiation bone. In bowel obstructions, the adjuvants used should be steroids along with octreotide and hyos or anticholinergic agents like hyos. So skeletal muscle pain is due to the skeletal muscle stimulation. We need to give laxants like thiocolchicide or tisanidine or chlorhexidine. So these are medications which will help along with the step medications which relieve the pain. So now we will move on to the next class of medications are the opioids. Any doubts so far? Okay, now we move on to the step three or step three medications where we are using opioid medications or the pain main for medications for severe pain. So now we have the medications we use for mild pain and moderate pain. Suppose a patient is coming with severe pain, crying out in pain. Many of us might have seen that situation. Think about a patient suffering from advanced pancreatic cancer coming to your OPD, coming to in front of you with severe pain, crying all over, catching at his abdomen, trying to hug his leg. So we might also. So what is something that we can do there? In such situation, if I give step one medication or step two medications, like so inpatient comes with severe pain in such a situation, is crying, injection paracetamol may not help him. Even tramadol injection or tab tramadol may not help him. In that situation, when the severity is high, the drug of choice should be step three medications or opiate for severe pain, which are morphine, fentanyl, methadone. These are the only three ones which are available in our country. So let me come back to the story. Like what can we do for this person who come in severe pain? So what we do is opioid titration. So we need to give opioid for it. So even if we are giving opioids, our usual practice is we might give 5 milligram or 10 milligram stat dose. See, thing with that is, uh, if we give 5 milligram, he might get relief if he's lucky. If his pain responds to 5 milligram of morphine, he will be lucky. If he's lucky enough for that, he will get relief. But if we get relief at 2 milligram, then we are giving 3 milligram extra for him, which will cause him toxic symptoms. If he is still unlucky, his pain may be responding to 8 milligram, which we do not know. Since we are giving blindly, he will not get satisfactory relief. So that is why there is a need of opioid titration, where we will give small boluses of morphine at regular intervals, giving him pain relief. This is what we call as parenteral morphine titration. So this is used by a large number of centers. This has been is very easy to use and very beneficial for the patient. So please kindly listen to this. So we call this as a parenteral morphine titration. So when a patient comes in severe pain, first thing we do is we give him injection metoclopramide. This is to prevent nausea and vomiting, which is associated with the opioid, which we are going to give. So to prevent that, we give an injection metoclopramide. Then we start with injection morphine. So morphine usually comes as 10 milligram or uh, 15 milligram ampules. So we dilute it into 10 ml. So we get a 15 milligram ampule. So we dilute it into 10 ml in a 10 ml syringe with distilled water. so that each ml is 1.5 milligram, which I will administer at a 10 minutes interval. So first dose I give metoclopramide, then I give the first dose of 1.5 1 ml of morphine, that is 1.5 milligram. Wait for 10 minutes, I repeat. This I will repeat till the patient gets pain relief, a satisfactory pain relief, or patient becomes drowsy. Whichever becomes first, I stop the titration. So satisfactory pain relief or patient becoming sleepy. So whichever comes first, I stop the titration. Till then, I will continue the titration. This is the basic of parenteral morphine titration. See, this is for one patient I have done. So I'll be monitoring the time, pulse rate, respiratory rate, BP, pain score, drowsiness, and the dose administered. At 10 o'clock, I assessed the pain score. Pain score was 10. I gave him, he was not drowsy. I gave him 1.5 milligram of morphine. Then I wait for 10 minutes. At 10:10, I asked the pain score. His pain score was 7. I asked him whether it's a satisfactory relief. He said no. Then I asked whether he's drowsy. He said no. Then I administer 1.5 again. Wait for 10 minutes. After 10:20, his pain score is 4/10, which is not satisfactory for him. He was not drowsy. I repeated. But if here he was drowsy, I would have stopped it. Now he was not drowsy. So 1.5 given. At 10:30, pain score and I asked, he said 1, which is a satisfactory for him. Then I asked for a drowsiness. But since he had pain relief, satisfactory pain relief, I stopped the titration. If at 10:20 he said he was becoming drowsy, I would have stopped because either satisfactory pain relief or the patient becoming drowsy, whichever comes first, we stop the titration. Okay. Now the patient had satisfactory relief at when I give 4.5 milligram in total, he had satisfactory pain relief, isn't it? So patient got satisfactory pain relief of the toxic symptom, which is a drowsiness. So this is how I will start the patient on morphine. I will convert it to the nearest dose of morphine tablet. So 10 milligram tablets are available. So we can give us half of the tablet, like 5 milligram tablet. That would be the nearest dose we can convert practically. Then I would give half a tablet, 10 milligram tablets, half a tablet. The duration of action for morphine would be 4 hours. So every 4 hourly, we give morphine tablet so that patient gets round the clock pain relief. So half a tablet when he wakes up, since it doesn't cause any gastric irritation, it can be taken on empty stomach. So when the patient wakes up itself, we give half a tablet so that he doesn't have to suffer in pain. So suppose if it wakes up at 6 o'clock, we give the next dose at 4 hours later at 10 o'clock. Then 4 hours later at 2 o'clock. Then 4 hours later at 6. Then 4 hours later at bedtime. Considering if it is 10 o'clock, he sleep. But please notice we give not 5 milligram but 10 milligram at bedtime. See, if we give the same dose, like half, we are giving 4 hourly. If we give 5 milligram at bed at 10 o'clock, we have to wake him at 2 o'clock in the morning for the next dose. So to avoid this nighttime waking up, we give double the dose of what he took in the morning at bedtime, so that we expect the patient to get pain relief. Double dose will pain relief for next 8 hours. The only thing like we expect is the patient becoming drowsy. Since it's a bedtime, he double that is not an issue. That won't be an issue. So for the next 8 hours, it is covered. and by 6 o'clock he's getting woken up. So we are requiring round the clock pain relief by force-early medication. Also, always prescribe an SOS dose. You all might be knowing about the breakthrough pain. In case a patient gets a sudden burst of pain, train the patient to take an SOS dose. Okay, so this is how we start. So patient came with severe pain. We identified the titrated the dose of medication, morphine, which gave him satisfactorily, and we switched him to tablet morphine and sent him home. This fourth hourly need not be given every patient. Should be reduced in patients who are very frail, very elderly, or patients with a renal injury, altered renal function. You need not start at fourth hourly. It can be started as eighth hourly or thrice a day. Okay, so just so hope this is clear. This is very important. So this is how we do parenteral morphine titration intravenously. In patients who we cannot get an IV route, we can give subcutaneous also. Only change there would be not 10 minutes. We have to give about 15 minutes apart. Hope I'm clear. In subcutaneous route, if you are administering the parenteral morphine titration, we have to wait for 15 minutes. Everything else is same. We start with metoclopramide. Every 15 minutes, we administer 1.5 and we calculate the end product and continue till satisfactory pain relief for sleepiness, whichever comes first. Then we can also use this for fentanyl, where fentanyl, since it's a very fast acting, we need not wait for 10 minutes. If it is IV, it is 3 minutes, and subcutaneous, it's 5 minutes. So if we are using fentanyl, we dilute it into 10 ml. So 1 ml would be 10 microgram. It's 100 ml ambulance system. So 10 microgram at every 3 minutes if IV and 5 minutes if subcutaneous. Hope I'm clear. Any doubts? Do you want to repeat this? Anyone want to repeat this? Yeah, good. So moving forward. So this patient was that. So in case there are no injection morphine available, we can also use tablet morphine for titrating. Only thing is, it takes. We can start with 5 milligram if the patient is opioid naive. That is, he hasn't taken any opioid before, or 10 milligram if who was already on tramadol or any other opioids. And we wait for 1 hour. We give one tablet, maybe if start with 5 milligram. We wait for 1 hour, reassess the pain, ask for sleepiness. If not satisfactory, we give another tablet. It takes a longer time compared to the parenteral route, but oral pill can be given in situations where injection morphine is not available. Suppose this person was started on 5 milligram ortholy and response. He was comparatively pain-free for a week. But now he's taking 4 SOS doses for morphine per day for the last 4 days. What should we do? We have to raise the dose because he's requiring more tablets, rescue doses in case of pain. When there are 2 or more than 2 rescue doses taken, or the PRN doses or SOS doses, however you call, so if we are requiring 2 or more, then increase the dose by 30 to 50% every 3 days. Only maximum 30 to 50% should be increased. That too every 2 to 3 days. So this person was on 5 milligram for 30. So if we increase by 30 percentage, 50% consider 5 milligram for 30. So 24 hours he's getting 30 milligram. quarterly means 6 doses. So 30 milligram is taking. 50% increase will be 45. Now cutting that in six, that is quarterly dose would be 7.5. Or need not like that. Simply a half of 5 milligram would be 2.5. Maximum you can reach is 7.5. Uh, okay, now the practical will be, it will be very difficult to break this 10 milligram tablet into 3 quarters, like 7.5 milligram. So we can also switch to 10 milligram. So this patient can be put to 5 or 5 from 5 to 7.5 or 10 milligram for thoroughly. That's maximum dose at a time. We have to increase. So we review the patient in 2 to 3 days. If not least, we have to again increase 50%. So how frequently should you give SOS dose is the next question. So for doing that, you need little pharmacokinetics for absorption. Once taken only, it undergoes a first pass metabolism in the liver. So it takes around 1 hour for the medication to reach the blood effectively. So it takes 1 hour. So when a patient took the tablet at 10 o'clock in the morning, the regular dose, but he has pain, we ask the patient to wait for 1 hour. So till 11 o'clock, we ask the patient to wait so that the drug will start acting in the blood. Even after 11 o'clock, if patient pain hasn't reduced, then we can give a rescue dose. So wait for 1 hour after the normal dose, then give the rescue dose of tab morphine. So, okay. So once if you are given rescue dose, that doesn't mean you have to skip the next dose. The next dose should be continued as instructed so that the pain doesn't come back after. Or only if you're taking the last rescue dose like half an hour before, you need to skip the next dose. Otherwise, do not skip the next dose. Even if the rescue doses are taken in between, that should be continued. And ask the patient to note down how many rescue doses of morphine they have taken and report it to us the next week. The metabolism of morphine is mainly through liver, minor parts in GIT and kidney. So 90% is converted to metabolites. We call that the morphine 3 glucuronide and morphine 6 glucuronide. The M60 or the morphine 6 glucuronide is the active component giving pain. So now the pain may be stabilized by 10 milligram morphine, but he finds it difficult, like taking it every 4th hour. Of course, it's very difficult. Like every 4th hour, the patient has to wait and look into the clock and take tablets. And he demands that he is willing to take if he's giving less frequently. So what can we do for him? So that is when the sustained release tablets come in. Definitely you can educate them, but think about from the patient's perspective. Sticking on to the clock, looking for 4:30 won't be easy. So sustained release tablets can be an choice here. So sustained release tablets, they act for 12 hours. So this patient, he was on 10 milligram very 4:30. So in 24 hours, he was getting 60 milligram morphine. 24 hours, 60 milligram. Sustained tablets are available at 10, 20, and 30 milligram. Here, he needs 60 milligram morphine in 24 hours. Hence, we can give sustained release tablet of sustained release tablets of 30 milligram twice a But this can only be done if there are no rescue doses taken. That's a stage one. Make sure they are taking the immediate release tablets also along with them. Ask them to keep in hand in case of a breakthrough pain comes up. So when a sudden pain comes up, the SR tablets they are taking will not help them. So they have to take a immediate release tablet with them. So this patient will be given sustained release 30 mg BD along with uh, 10 milligram immediate release also as SOS. Morphine is available in solutions, immediately and sustained release tablets and injections. 15 milligram per ml and 10 milligram per ml injections are available. Now, this patient on 10 milligram for past 6 years. He came with severe drowsiness. In examination, you found that the creatinine is 5 milligram. What can we do with the morphine dosage? The excretion of morphine is through glomerular filtration, so the kidney. So, if there is a renal function is altered, the M6G accumulates in the body. So, becomes there are the toxic symptoms like drowsiness will come up. So, for this patient, such patients, we have to increase the spacing. So, rather than giving fourth early, we have to reduce it to thrice a day or reduce the dose to half. Since you are taking 10 milligram for thoroughly, you can reduce it to 5 milligram for thoroughly or reduce it to thrice a day. Or choose an alternate opioid which will be safer in renal function like a fentanyl or methadone. Now the patient is sent home, now taking 5 milligram thoroughly. After 2 months, he becomes unable to swallow anything, including morphine. What can we do? This patient is at home, unable to take orally. What can we advise for this patient? So this patient called from home and asking you like he's not able to take tab. What can we do? Advice for this? Nasogastric subcutaneous would be advised, but in home, let's discuss it. Morphine can be also oral route and parectal route. So this parectal administration is as effective as the oral route. The dose will be same. For a patient who's at home, parectal administration would be a good option. Without any intervention at home, the caregiver itself can provide parectally. Only thing they have to do is take the immediate release tablets, add few drops of water, make it like a paste and apply it to rectal mucosa. So rectally, like paracetamol or diclofenac or any other suppositories, we can administer morphine. So this patient, we can advise to give 5 milligram per rectally 8 hours. But the immediate release acting tablets has to be given. Another lady with carcinoma colon was on 10 milligram morphine for thoroughly and is not requiring any rescue doses. The doctor has asked him to place 25 microgram fentanyl patch. Next day, the patient come back to you telling that they removed the fentanyl patch after 5 hours as they didn't have pain relief. What can we do? What will you do? See, to answer this, you need to know how fentanyl is doing. The fentanyl can be available in injection, transdermal, like the patches, and oral fentanyl citrates. Those are the lollipops. Fentanyl lollipops are available, not available now. The fentanyl patches help through. Once you stick the patch on the body, it forms a subcutaneous depot of blood. Initially, the subcutaneous depot is formed once through the patch, and it starts getting distributed through the body. Effective analgesia will take place only after 8 to 12 hours. So for the 8 to 12 hours, the patch, the fentanyl will not act properly. We have to educate the caregiver that this takes around 8 to 12 hours. But we cannot ask the patient to suffer for the 8 hours. So we advise them to continue the same medication which were there on. Like if so consider this lady, the patient B, like he was on 10 milligram morphine for the. So when she apply the patch will become effective only after 8 hours. So for the next 8 hours, we advise them to continue morphine, but at a half a dose to reduce the to avoid toxic symptoms. We will advise the patient to take 5 milligram morphine for the next 8 hours till fentanyl patch has started action. So such education has to be given when you put the patient on fentanyl patch. The fentanyl patch lasts for 72 hours. So every third day, the patch has to be changed. Skin condition and temperature affects absorption. So we need to choose a hairless area skin without any wound or infection or inflammation. In increased fever, temperature like fever can increase absorption. So there are also toxic symptoms can occur. So that should not be done. And advise the patient not to shave the area of fentanyl patch because micro abrasions when you shave the area can increase absorption of fentanyl. So that is also a risky issue. And fentanyl is not suitable for patients with unstable pain. Like the breakthrough pains are there, they should not be put on fentanyl patches because the patch acts as a continuous infusion. So there won't be any hikes of doses in case of a breakthrough pain. So this patient, we could have advised them to wait for 8 hours and continue morphine till the next 8 hours for half the dose. The patient who has a neuropathic pain on morphine, amitriptyline, pregabalin comes to clinic with delirium and myoclonus, but no pain relief expected. How will you manage this patient? Here, the patient has significant neuropathic pain and toxic symptoms of opioids like delirium and myoclonus. So morphine cannot be high. So we have to switch to another medication which is more suitable for us. Fentanyl would have been an option, but if we see the history, patient has more neuropathic pain. So methadone would be the drug of choice for this patient. Methadone is introduced in India since 2019. It has three modes of action. It is an opioid receptor agonist, has an NMD antagonist, and SNRI inhibitor. So it's a very effective for neuropathic pain, but it's not commonly used because of the drug interactions. So there's a drug interaction with almost many drugs we use in common day, like pantoprazole or ciprofloxacin, several drugs, and it has a high risk for cardiac abnormality by QTC prolongation. It calls it toxicity points. So QTC prolongation, it has a higher risk for uh, cardiac issues. So such patients would be screened and only select patients, certain conditions of patients can be used. But these are very effective in neuropathic pain and patients with severe renal issues. And even for higher dose of patients with higher dose of morphine, lower doses of fentanyl would be sufficient. It's longer duration of action, so the dose can be escalated only 5 days later. It takes 5 days to assess whether the current dose is effective. So dose escalation will happen only on 5 days. Methadone is available as tablets and syrup. Now, see this patient, carcinoma lung, complaining of throbbing pain right side of chest, continuous, but only 5 by 10. That's a moderate pain. He is non-epileptic and on phenytoin 100 milligram. How will he manage it? Looking at the severity, we chose a pain medication. He is complaining of moderate pain. But ideally, I would have chose tramadol. But since he is epileptic, he is at a higher risk for the seizure. Tramadol can reduce the seizure potential and throwing seizures. So, will not start him on tramadol, but lower dose of step 3 medication or lower dose of morphine can be started for this too. Need not wait for tramadol. Okay. Just another medication. Like if you have tablet, sometimes Fortwin is one of the medications commonly available. Suppose this patient, some 50 milligram morphine comes to severe pain. You have injection Fortwin and injection morphine, tab morphine. You have injection of Fortwin and tab morphine. Which one will you give up? Since the patient is severe pain, many of you will be answering about injection pentazocine or injection Fortwin because that's a tablet morphine out. But that is the wrong option. Why I will say because before that you just need to know the opioids. Opioids acts through three receptors: mu, kappa, and delta. Based on the action, it can be agonist, antagonist, and agonist-antagonist. Agonist means acts on the receptor and cause pain relief. See, here, this is an agonist. This is pain relief against the dose. As dose increases, the agonist acts causing pain relief. It will attach to the receptor and cause a pain relief. But antagonist will this antagonist medications, they will act on the receptors, preventing agonist to act. So when the agonist comes, they won't be able to give pain relief. So when agonist antagonist medications, so these have partly agonist and partly antagonist. So when you start giving the medication, the agonist will attach to the receptor, causing pain relief. Meanwhile, the antagonist present alone will be replacing the agonist from the sides and prevent further agonists to act. So there won't be, at this point, there won't be no agonist receptors available. All the receptors will be occupied by antagonists. So beyond this point, there won't be pain relief. So as much as even though the dose is increased, pain relief will not increase as an agonist because there are no receptors available. So this is what we call as a ceiling point. So in agonist antagonist medications, beyond a certain point, it will not give pain relief. That's with the agonist and antagonist. Morphine, fentanyl, tramadol, they are all agonist medication. Antagonist medication is naloxone and naltrexone. These are used in opioid toxicity. How to identify opioid toxicities? When the respiratory rate is less than 8 and patient is unresponsive or responds only to pain. If respiratory rate is less than 8, patient on opioid, respiratory rate falls less than 8, look for the consciousness. If it's unresponsive or responds only to pain, we have to give naloxone. If patient is alert or easily arousable or opens on verbal command, we can wait but skip the next dose or reduce the dose. Management would be airways to be maintained. Oxygen, maintain oxygen and SpO2 more than 95 would be ideal. Stop the opioids. If it is a patch, remove the patch. If it's a tablet, don't give next dose. If it's an infusion, stop the infusion. Get an IV access and give naloxone. Naloxone should be administered over 30 seconds. Assess after 1 minute. So you see the patient is on respiratory rate less than 8 and is unresponsive. Start 400 microgram IV over 30 seconds and assess after 1 minute. If no response, give 800 microgram over 30 seconds. Reassess after 1 minute. Still no response, give another 800. Still no response, give 2 to 4 gram. And if even after 4 gram, no response, then the patient is not suffering due to opioid toxicity. So not due to opioid toxicity, we have to look for other causes of respiratory depression. Yes, so once you give, after the last dose, patient is better. Now then continue monitoring for consciousness and respiratory every 15 minutes for the next 2 hours and hourly for the next 6 hours if it was immediately tablet, 12 hours if it was sustained these tablets, and 24 hours if it was methanol. See, coming back, the pentazocin or the fortmin injection, they have an agonist-antagonist action. So compared to the morphine. Morphine is a mu agonist. It will continue pain relief till the dose continue. But pentazocin will replace morphine. So for the patient we discussed earlier, if we would have given injection morphine or the pentazocin, it will replace the morphine tab only so that after some time the patient will not get pain relief. So the patient will come in will have severe pain despite how much morphine or any other medication you give after the ceiling point. So always give agonist medication in such situations. Yeah. Just about the side effects of opioids. Constipation is the most common. It's seen in 95% of the patients. It lasts long as till the morphine is, or the fentanyl is there. Uh, so it will be same 95%. So make sure that every patient on opioid should be started on a stimulant laxative because it works by reducing the gut motility. So stimulant laxatives like bisacodyl should be prescribed to all patients on morphine. Nausea and vomiting is another common adverse side effect, which is seen in 1/3 of the patients on first few days. First 3 days is the most common issue, uh, but it is self-limiting. So after the third day, it may not be there. But due to the vomiting in the first 3 days, the patient might stop medication. So we have to give antiemetics for this patient. This is due to the stimulation of the chemoreceptor trigger zone. As we discussed earlier, the CTC. So we need to give an antiemetic which acts on CTC, which should be haloperidol, metoclopramide, or domperidol. Sleeplessness and tiredness. So advise the patient, like 1/3 of the patient will become sleepy initial time. It's also self-limiting. So whenever you're starting the patient on napkin, advise them that there will be tiredness and sleepiness in the initial 3 days. After that, it was self-limiting, so it won't be there. So do not ask them not to stop the medication because they become tired. These are the side effects. So these will be present whatever the situation it is. Just one more thing, the itching. There are rare situations where opioid-induced itching, it's not due to allergy. There won't be rashes, but the patient will start having itching when opioids are started. So this is called opioid-induced itching. It won't respond to anti-allergic drugs, or there will be rashes. So the drug of choice there would be ondansetron or anisette. Now these are the side effects. Now there are toxic symptoms which appear when the dose administered is higher than required, or when the pain has poor response to the opioid, or if the renal system is not proper so that the drug accumulates. There are three of the toxic symptoms: delirium, myoclonus, and excessive drowsiness. So make it a habit to assess every patient who is on opioid who comes to follow up to in whether they have delirium, myoclonus, or drowsiness, and record that there are no toxic effects of opioids in them. Make sure this is asked for every patient so that you don't miss that. In case there it is, we have to switch medication or reduce the dose. Just to one more thing, uh, Does opioid produce respiratory depression? When taken by mouth, in the medical doses advice that we prescribe for pain, respiratory depression is very unusual. Um, Very rarely that occurs, but more seen in IV doses, not by oral, that too in very high doses. So respiratory depression is very unusual. Even then, if you see an depression, there would be other reasons like pneumonia or pulmonary embolism or cardiomyopathy or co-administration of a sedating medication like a benzodiazepine, which should have caused the respiratory depression. So addiction also is another concern. The substance abuse as a result of medical use is very low, and there is always overestimation of dependence. So in medical users and patients with severe pain on oral route, the addiction potentially is much lesser compared in terms of morphine and other opioid medications in controlled use. Thank you. That ends my session.
Dear participants, kindly ask your doubts if you have any doubts. Kirtana? They are saying thank you, sir. I think there is no doubts. Hello? Hello? Am I audible?
Trying to answer.
So they are saying that session was excellent.
Thank you. Thank you.
Yes, sir. So I hope everything is clear. So I can understand your situation, sir. So you can leave now.
Thank you,
Thank
Anna.
you. Thank you for
Thank
the
you.
insightful session. And okay, sir.
Thank you, everyone.
Okay.
Have a good day.
Okay. Thank you, sir. Dear participants, you can leave now.